Welcome, everybody, to the Kona Shane Veterinary Podcast. I am your host, Dr. Andy Roark, back with my good friend, the one and only Tasha McNerney. We are talking about anesthesia and analgesia in itty-bitty kitty cats today. This is super fun. It's really interesting. I think a lot of us don't think enough about these types of patients, but we certainly see them. What do you do for a cat that weighs less than 1 pound? Got you covered today. Guys, this is a great episode. Let's get into it.
This is your show. We're glad you're here. We want to help you in your veterinary career. Welcome to the Cone of Shame with Dr. Andy Roark.
Welcome back to the podcast, my dear friend, the original anesthesia nerd, the one and only Tasha McNerney. Thanks for being here.
Me again.
Always my pleasure. For those who don't know you, you are a lot of things. You are a wonderful lecturer. You have been the Vet Tech Lecturer of the Year at the VMX conference before. I have met you at conferences. Actually, we met in Reno many years ago, and I've seen you speak a number of times. You and I have spoken together. We did a Hall & Oates themed track. They gave us a whole track to do something on vet med lessons from Hall & Oates, which I don't know. I don't know who signs off on these things, but
I know. I don't know how that got approved when I pitched it, but the fact that they were like, yeah, great. My only regret is that you didn't that we didn't do the whole full on costume.
We did, yeah.
You as Oates and me as Hall, and
I have a fake
it could have been so good.
I know. I have a mustache now I could have worn.
I mean, we might need to resurrect this.
I agree. So anyway, we have a history of highs and lows. We've made goofy internet videos together. But anyway, you are also a technician specialist in anesthesia, analgesia, and the founder of an enormous Facebook group called the Veterinary Anesthesia Nerds, which also has its own conferences now and things like that. It is really metastasized, if you will. And it's a force of good in the world. You do great things. Anyway, you are my go-to for in the trenches, on the ground, anesthesia, analgesia questions. And I've got one for you. Can I ask you about it?
Of course. Let's do it.
Oh, okay. This is a case that everybody's seen, but I just had it, in all honesty, I just had it a week or two ago. And so I got this little black kitten. So it was about 0.8 pounds. And it's just a black domestic short hair kitty cat. And someone had just found it beside the road, and they brought it in and they said, I would like to have this cat and to get it cleaned up and give it a home. And I said, I think that's great, and I want to support that. And as I look at this cat, she has got a big swelling under her right mandible. So on her neck, there's this big swelling. And I go and I look, and there's a draining tract, and as I squeeze it around, I think that there is a cuterebra in there. There is some sort of parasite inside this draining tract. It's not just infection. And so I've got this itty-bitty kitten, true story, less than 1 pound, probably 4 weeks old. And I just am wondering to myself, I don't want to ruin this cat. I don't fear free all the way. And it's sort of like, I want to make sure that I'm keeping this little booger comfortable, because this is going to hurt. There's no way this doesn't hurt to have this thing pulled out of your neck, especially if I have to open the tract up a little bit to get to it. And so I just want you to go through with me, Tasha McNerney, talking about a cat like this size, anesthesia, analgesia. How do you treat that? Give me some best practices. Help me make sure I'm doing a good job.
Yeah. So there's a lot of things. First off, right off the bat, what I would want to know with this kitten is, especially in the location that you're telling me, is there any way that we have compromised the airway? We did have a kitten very similar to this come into a practice I relief at, and spoiler alert, you guys, this doesn't have a great ending, but it had multiple cuterebra, and one of them in the neck area had migrated enough that it had caused a tracheal rupture. And euthanasia was chosen for that kitten just because surgical correction, even with surgical correction and a tracheal stent, might not be. So again, that's always kind of in the back of my mind. Has it kind of compromised our airway in any way? If so, we still can work with it.
Thanks for giving me something new to worry about. That had never crossed my mind before. And now I'm like, oh, now I got that to worry about. Thank you for that.
Well, it's vet med. There's always something new to worry about.
Let me tell you something you never even considered that I've seen before. Oh, God.
Yeah.
All right. Okay. No, I'm on board.
Right. So let's
Note
say,
to self.
Note to self. Just make sure that trachea. Again, you don't have to go through like a full on let's get a CT. Again, unless you're just feeling really ambitious. But other than that, if you feel like your airway and pulmonary wise we are okay.
Yep.
All of anesthesia is preparation. I know that a lot of people think that anesthesia is kind of boring in the sense that a lot of these procedures were like sitting and monitoring and just writing stuff down. There's not a lot of movement, fast-paced action. And listen, all of anesthesia is just preparation to make sure that we don't have fast-paced action once the animal gets onto the table. We want to make sure that we are planning as much as possible. And for a little kitten like this, at 4 weeks, around 4 weeks old, around a pound in weight, this is really tiny. So we want to plan correctly. And again, a full physical exam as much as we can. These little guys are really dependent on heart rate in order to maintain that cardiac output. And remember, we need cardiac output to be maintained because our blood pressure is dependent on cardiac output. So for these little guys, they kind of come in with that high heart rate. The whole thing during anesthesia is I want to keep that heart rate as close to normal or even a little bit higher as possible, because as my heart rate gets lower and lower, or the patient gets bradycardic, that's going to drop my cardiac output. And the reason we care about that is that cardiac output is going to influence oxygen getting delivered to the things that we care about, the liver, the kidneys, the brain, etc. Also with these guys, the pulmonary reserve is limited, right? So they can get hypoxic faster. So these guys definitely always make sure if you're giving them any kind of drugs or sedative, it's in the presence of oxygen. You have supplies ready to go to to intubate them. Now, these guys are ones that I'll tell you, sometimes I'll use them in birds and reptiles, but for these really tiny little guys, I might choose an uncuffed endotracheal tube, like an appropriately fitting uncuffed endotracheal tube. So that way I don't have to put a tiny tube in and then push that reservoir cuff on the endotracheal tube. Because, too much pressure on these little guys can cause some tissue necrosis in that trachea. So these, I have a selection of not only cuffed, but also uncuffed tubes for them as well. Now, these guys also, again, everything's underdeveloped. So that's what you just got to plan on. Their sympathetic nervous system is also underdeveloped. So that means that drugs that are going to work on the sympathetic nervous system. So again, things like ketamine, tilazol, that kind of stuff. Those drugs usually will get a sympathetic response, and we see an increase in heart rate and a little bit of increase in cardiac output with them. But we don't tend to use ketamine and teletamine in these really tiny patients, again, because that sympathetic nervous system is underdeveloped. They don't have the same response that a adult or an animal of maturity would have. Also, these animals get very hypoglycemic fast. So before I give any drugs, I want to check a BG and make sure that we're in range, and I want to be ready to supplement with dextrose as needed. Again, we're constantly checking BGs. Now, with a Cuterebra patient, hopefully they're not going to be under anesthesia or sedation for a long period of time. But certainly I have done some amputations on very tiny, tiny little guys where they might be, under anesthesia for up to an hour, and we're every 15 minutes checking BGs on them. Also, with these guys, thermoregulation is going to be a big one. So before you get this patient sedated, you want to plan on how are we going to keep them warm, whether that's a bear hugger, whether that is just, covering their the body in bubble wrap and providing either active or passive warming. You want to have a plan for warming, because in these little guys, that larger surface area to body weight ratio means that they're going to lose heat much faster. And then if you intubate them, you almost always are putting these little guys on a non-rebreather. And remember that high flow of oxygen from a non-rebreather is going to contribute to them getting colder faster as well. So just be ready with a plan for thermoregulation. If you have the opportunity to, if it's a planned procedure, you know they're going to come in, again, with the hypoglycemia and et cetera, the fasting recommendations for these guys are no more than 3 hours. So we want to make sure that they have not been, these are not patients we fast for 8 hours or even overnight. We really don't want to do fasting with these guys. Once we have all of our stuff together, right? You have your stuff for intubation, you have your oxygen, your heat support protocol, all that. If you want to talk about drugs, again, I already mentioned that I probably would stay away from things like ketamine, talidomide, which is a component of tilazol. But maybe I'm going to go with an opioid. And usually the pure mu opioids, whatever is your opioid du jour at your clinic, maybe you are a hydro clinic, maybe you're a methadone clinic. Again, I always say dealer's choice when it comes to mu opioids. I am equal opportunity opioid. So if you want to do hydro or methadone, whatever it is, the nice thing is that it's reversible. So we just tend to go a little bit lower on our dose, but opioids are pretty safe for these guys. Now, if you give a big dose or if you're giving fentanyl IV, you might see a reduction in heart rate. And again, these guys are really dependent on heart rate. So I always have a dose of anticholinergic drawn up and ready to go for these patients. And in some cases, especially in the neonatal, not in this case, but a really tiny brachycephalic patient, because of their high vagal tone, this is the one area of patients where I am going to put glycopyrrolate into their pre-med to kind of offset any of that reduction in heart rate and therefore reduction in cardiac output. So I always have a dose of anticholinergic. Now, some clinics don't have glycopyrrolate. You might have atropine. So again, whatever you have at your clinic, just make sure you have a dose of anticholinergic drawn up and ready to go. Not like over there on a shelf in the same room with you, but actually calculated, drawn up, ready to go with these. And then the next thing that we consider is if we're going to put a catheter, if we're going to intubate them, you can give them an opioid and then a local anesthetic, just like a little bit of lidocaine just around the area of the cuticula to cut those pain signals going to the brain for when you actually have to open and widen it and like that pull that cuticula out. So I like a combination of opioids and local anesthetics. Definitely some flow by oxygen and ready to intubate as needed. Again, the timing of these procedures, you could make the case that, intubation in itself, because it has complications, this might not be warranted. But certainly if you were dealing with something like an amputation or a longer procedure, you would want to intubate these patients to have control of their airway. If you needed something a little bit more, there's always alfaxolone, which you could give a small dose of alfaxolone IM. Now, again, with alfaxolone, you're not providing any pain control. And alfaxolone is one of those drugs that if you do use it IM, which is off-label in the US, but on-label in New Zealand and Australia, if you're using alfaxolone IM, just remember, alfaxolone doesn't play nice by itself. Alfaxolone needs a buddy. It needs a friend. Now, that friend can be an opioid, that friend can be something like midazolam, but alfaxolone doesn't go well by itself. When we use alfaxolone IM by itself, you tend to see nystagmus, muscle tremors, which some people mistake for seizures, et cetera. So that's why I always say, make sure if you're giving alfaxolone, you're pairing it with something else. And in this case, we would be, we'd be giving this kitten an opioid of some sort. Does that all sound good?
That all sounds good. So there's a lot there. That all matches up. I'm frantically taking notes over here. Yeah, that's really helpful. Hey everybody, I'm just jumping in with 2 lightning fast updates. Number 1, if you have not gotten signed up for the Get Done Shorthanded Virtual Conference in October, it's October 6th through the 8th. You need to do that if you are feeling overwhelmed in your practice, if you want things to go smoother and faster, if you do not want to watch webinars, you want to actually talk about your practice, you want to do some discussion groups, you want to do some workshops where you actually make things and work on things and ask questions as we go along and have roundtable discussions and things like that. That's really going to energize you and help you figure out actionable solutions that you can immediately put into practice to make your life simpler and more relaxed. I got you covered, buddy, but you don't want to miss it. Go ahead and get registered. Mark yourself off at the clinic for the time so that you can be here and be present and really take advantage of this. I don't want to sneak up on you. I know October seems like a long way away. It's not. But go ahead. I'm going to put a link down below, and then when registration opens, we'll let you know it's open and you can grab your spot. But you do not want to let it sneak up on you. Check out our Get done shorthanded conference. It's going to be a great one. The second thing I'm going to tell you about is Banfield. Thank you to Banfield, the pet hospital, for making transcripts of this podcast available. You can find them at DrAndyRoark.com. They are totally free and open to the public, and Banfield supports this to increase accessibility and inclusion in our profession. It's a wonderful thing that they do. Guys, that's all I got. Let's get back into this episode. Do you have a thermoregulation preference for an itty bitty like this? Is there something that you think is more effective with something so tiny? I imagine this little speck disappearing underneath a bear hugger, like kind of hovering over top of the kitten, because there's just so little there. Yeah. Do you have give me some advice? Or do you, even if it's just you say dealer's choice, even if it's personal preference, what do you like for helping maintain body temperature in itty bitties?
Yeah, these really tiny ones. I do still think that an active warming, such as like a hot dog or a bear hugger or a warm water blanket, is the way to go. Okay. Certainly, as you said, we can't use a regular, even the small size bear hugger blanket. This kitten is going to disappear under. But we can, a lot of people, if you have bear hugger blankets in your practice, they come with these little plastic inserts. And most of the time, people just throw them away. I'm going to tell you, don't throw them away, okay? You can actually use the plastic sticky things that come in with it. They come with the bear hugger so that you can put the plastic around, and they actually help to seal in the juices as far as the heat goes. But again, most people just throw them away. Don't. Keep them around, because you can stick them kind of like long ways over your patient, and then you can just finesse the bear hugger output or the warm air output underneath this plastic. And again, you could use something like bubble wrap as well, and then provide the bear hugger underneath that. But usually I have it on each side. So I might have a warm water circulating blanket underneath the patient. And then I might have the bear hugger or even a hot dog around it. Now, I will say I'm a fan of the hot dog. What I like about it is that unlike the bear hugger, you don't have to worry about things blowing around your surgical site. And the nice thing is, for these really tiny patients, the hot dog does actually make a very tiny size hot dog blanket. It is adorable if you have the chance to see it, but it's made for like hamsters and gerbils. So it's really tiny, and it will wrap around the patient to provide active warming. So if you have a hot dog in your practice already and you are dealing with small cats and kittens, I would say invest in one of these, because it is really nice to wrap them around. And again, it's just freaking cute.
All right. I feel good about that. So I'm feeling good about all of this, honestly. So up to our procedure, this all makes sense. I can lay all this stuff down. I have everything in the clinic. This is perfect. This is really, really great. Do you have any advice on analgesia post-procedure?
Yeah. So for these guys, analgesia post-procedure, hopefully, here's the thing. Unfortunately, what you're going to be dealing with is some inflammation. And we just don't have, or at least I would say that I would be a little bit uncomfortable giving something that's 4 weeks of age, a non-steroidal anti-inflammatory. Right. So with this patient, you could consider things like oral transmucosal buprenorphine for analgesia. If you have